Well, it gives me great pleasure to introduce the speakers this morning. I ran through the list just very quickly and noticed that they were virtually all products in one way or another of the NCI and the NCI Navy Medical Oncology Program or the MGH Fellowship Program. And when you see young people come into a fellowship, you wonder, well, what will come of their career? And I no longer have that concern because they always have been so productive and so smart, and I'm so proud of them. And Alice Shaw is our first speaker, and she's just a great example of the talent that comes through this fellowship program here in Boston. So Alice is going to speak about ROS kinase as a target for cancer therapy.
I'm actually going to talk a little broader about ROS as well as another target. Here are my disclosures. Just going to start with an overview, and of course everyone here is familiar with this idea that lung cancer is no longer regarded as a single disease, but in fact can be regarded as many different diseases, each of which can be defined by an underlying oncogenic driver, such as KRAS mutation or EGFR mutation. And this pie chart just emphasizes how complicated our understanding is now becoming of the genetics of lung cancer with all of these different subsets, some of which are extremely small. What we're going to focus on today are the ALK subsets. So those are patients who have tumors that have an ALK rearrangement, anaplastic lymphoma kinase. That's present in about 4% of our patients. And we'll also focus on another small subset of patients defined by rearrangements of the ROS gene that Bruce was just mentioning, and those are present only in about 1% of our patients. I should point out that although some of these percentages are on the smaller side, because there are so many patients with lung cancer worldwide, these small percentages actually do translate into pretty large absolute numbers of patients. So for example, in terms of patients who have ALK-positive lung cancer, there are probably over 40,000 patients every year worldwide with that small subset of lung cancer. So this field, of course, all got kickstarted by a pretty seminal discovery back in 2004 by two different groups reporting that EGFR mutations underlie the sensitivity of patients to EGFR, an EGFR inhibitor, gefitinib. So this is the New England Journal publication from the Mass General group here that showed that, for example, this patient who has this extremely dramatic response to gefitinib was found to have an activating EGFR mutation. And so this set the field going in terms of thinking about these subsets of patients who have what we call oncogene-addicted cancer, so tumors that are driven by a particular oncogene and hence are very sensitive to inhibitors of that oncogene. And then, of course, this now leads to this general broad concept of what we all hope to do, I think, in oncology, which is personalizing cancer care. And basically, again, viewing lung cancer not as one disease, but as many different diseases, as sort of schematized by the different colors of patients, and then being able to define those patients based on their genetics, and then based on their genetics, directing them to the best therapy. So that's what's illustrated here. We've already established that for EGFR mutations, the best therapies up front are EGFR inhibitors like gefitinib and erlotinib. And what we'll talk about today is the data for ALK and ROS as new oncogene or targeted therapy paradigms. So I'm going to talk about three separate but related stories in lung cancer. I think these are some recent advances that we only really just recently reported and haven't even published yet. The first story we'll talk about is ROS, because that is one of the newest targets that we have in lung cancer. And we'll talk about some of the data that's emerged confirming that ROS is a drug target in lung cancer and potentially other cancers as well. Then we'll switch and talk about ALK and Crizotinib, and I've talked about Crizotinib at every meeting here for the last few years, but really what we'll focus on today is the latest data on Crizotinib that now shows that Crizotinib is indeed the most effective therapy for those patients with ALK-positive lung cancer and is more effective than standard chemotherapy. And then finally, we'll end on, I think, the major problem in the whole field of targeted therapies, which has to do with the development of resistance. And obviously, we'll focus on ALK in particular and talk about some promising strategies that we now have to overcome resistance in the clinic. So let's talk about ROS first. So ROS encodes a receptor tyrosine kinase gene that actually is very similar to ALK. And shown here is the phylogenetic tree for tyrosine kinases, showing you just how closely related ALK and ROS are. They're both members of the insulin receptor superfamily, and you can see in this little tree diagram that they are the most closely related tyrosine kinases to each other. In fact, a lot of that homology lies in the tyrosine kinase domain of these two proteins. You can see there's about 77% amino acid homology in the kinase binding sites. They're shown up here sequence-wise, and then down here is some computational modeling showing an overlay of the kinase domains of ROS and ALK, shown in green and gray ribbons. And actually what we've shown here is Crizotinib, actually, which is bound to ALK and ROS, and you can see that Crizotinib binds almost in an identical way to ALK and ROS. And again, this is very consistent with what we know about the relationship, the close relationship between ALK and ROS. So it turns out there are rearrangements, chromosomal rearrangements involving the ROS gene that were first identified in lung cancer in 2007 by the cell signaling group in Beverly. And since then, there have now been a number of different ROS rearrangements identified in lung cancer. They're schematized here. And basically, in all of these rearrangements, a portion of the ROS gene, which includes the tyrosine kinase domain, is fused to any of a number of these different 5' partner proteins, and that leads to now the constitutive activation of the ROS kinase, which drives transformation of cells. What we know now, as I mentioned earlier, is that ROS rearrangements are present in a small percentage of our patients, about 1% of our patients. I should note that ROS may also play a role in other cancer types besides lung cancer, particularly GBMs and cholangiocarcinoma. Since the original discovery of ROS rearrangement, we now know that this really defines a subset of patients who have pretty distinctive clinical pathologic features. They tend to be younger patients, like our ALK patients. They're by and large mostly never or light smokers, and most of the patients have adenocarcinoma histology. I think it's also important to note that these oncogenic drivers like ROS and ALK tend to be mutually exclusive, so we really almost never see overlap of these oncogenic drivers. So they really are the only sort of the sole oncogenic driver that's driving the growth of the cancer. So once that discovery was made, Dr. Iafredi here at Mass General developed a break-apart FISH assay, very similar in principle to the ALK break-apart FISH assay. That's now the standard diagnostic test for ALK. For ROS, it's a very similar idea. We're in the presence of a rearrangement involving the ROS1 gene. The red and the green probes, which actually flank the ROS gene, are separated. And so what we look for is separation here, or splitting of the red and green, or sometimes we just see isolated red signals, and that indicates the presence of a ROS rearrangement. So this has now become the standard test for screening patients for ROS rearrangement. And last year I showed you this case because we had just started identifying patients and directing them to Crizotinib because there was evidence from preclinical studies as well as from those modeling studies that Crizotinib would inhibit both ALK and ROS. So we started directing these ROS-positive patients to Crizotinib, and here's one patient that we showed last year, a patient of mine, younger patient with extensive disease at baseline. And last year we showed how he had this really miraculous response, so dramatic sensitivity to Crizotinib, so an ALK inhibitor actually also inhibiting ROS. And this patient actually continues on study today, now about 18 months later, so he's had not just a marked but an extremely durable response as well. Well, since then, the phase 1 study of Crizotinib has been enrolling, has a dedicated cohort to enroll ROS-positive patients, so he was just one of about 30 now. Shown here is the latest data on this ROS cohort of patients in the phase 1 study that was presented at ESMO by Dr. Yu. And here we have, at the time, we had 23 patients on study. Shown here are the demographics of those patients, showing that, again, most of them are younger patients, never light smokers with adenocarcinoma histology. Many of these patients were previously treated. And here's the latest waterfall plot showing the tumor responses across all of our ROS-positive patients who are treated with Crizotinib. And as you can see, I think everyone's almost getting tired of seeing waterfall plots like this, but this is a pretty amazing waterfall plot showing that basically almost every patient who has ROS-positive lung cancer is sensitive to Crizotinib, with as shown by all of these downward bars. And here we've also shown the durations of response below each of these bars. And these are not short durations. Again, these are quite durable responses that we're seeing. Now, just one point about this slide, or 2 points about this slide. Over here, you see 2 bars here that are blue for progressive disease as best response, and I wanted to explain both of those cases. This particular case was one of our patients who had an atypical ROS-FISH signal. And so even though it was atypical, we thought, well, there's some abnormality that's affected ROS, so we allowed him to enroll in the study. He did not respond. He, in fact, had progression, and Dr. Iafredi went back to his tumor sample. And now using 5' race, he determined that ROS was actually not rearranged. And so that was an atypical or false positive ROS signal. This is not even a ROS-positive patient, but we've included him in the ROS-positive cohort. This patient here, who also had progressive disease as best response, was also another kind of complicated story where this patient went on to Crizotinib. He is truly ROS positive. He was on for about 1 week and then had a non-study drug complication requiring that he hold study drug for the next 6 weeks, and then he had his first scans. So he was off drug for 6 weeks, had his scans, which showed a new lesion. So although there was some response, he actually had a new lesion and qualified as progressive disease. Well, this patient went back onto Crizotinib and actually had about a 60% reduction, and that's not captured here. So the point of me telling these stories is that really ROS is a marker, just like ALK, of patients who are very, very sensitive to Crizotinib. So here's the data, sort of in numbers, showing the activity of Crizotinib in these ROS-positive patients. And the reason I put this up is really to show you how similar our data for ROS looks to the original data that we had for ALK over 4 years ago. So in the original data that Dr. Kwok presented at ASCO in 2009, we had about, at that time, a little under 20 patients who were ALK positive and who were treated with Crizotinib, and their response is showing here, response rate of 53%, disease control rate of over 80%. And you can see lined up with that are now the ROS cohort of patients, almost the same number, about 20 patients, same response rate of about 50%, same, very similar disease control rate. So again, just emphasizing that ROS and ALK define 2 subsets of patients for whom Crizotinib is extremely effective. So now let's move on to ALK, because I think everyone's very familiar with the phase 1 and phase 2 single-arm studies of Crizotinib in ALK-positive patients, but now we finally have randomized phase 3 data that supports the use of Crizotinib in ALK-positive patients. So just to remind you about ALK as a target in lung cancer. Now, this discovery was made by Dr. Mano's group in Japan, again, back in 2007. And here he identified for the first time the presence of ALK rearrangements in a small subset of non-small cell lung cancer patients. And he showed in really his very important Nature paper in 2007 that these ALK fusion proteins that result could drive the growth of the cancer. So these are potent oncogenic drivers, just the way ROS fusions are potent oncogenic drivers. And these rearrangements can result from inversions or translocations that now fuse a portion of the ALK gene to any of a number of different 5' end partners, such as EML4. Well, we now know, as I mentioned, that ALK defines this subset of patients, about 4% of our patients, and just like ROS patients, these are patients with distinct clinical pathologic features. They tend to be our younger, never or light smokers with adenocarcinoma histology. And I should point out, we know a fair amount about ALK-positive lung cancer in terms of its natural history now, and ALK, unlike EGFR, does not seem to be a favorable prognostic factor. If anything, ALK-positive patients tend to do as poorly as the general population of lung cancer patients when Crizotinib is not used. So this is an important disease for which we need therapies like Crizotinib. So this is to remind you of some of the early data on Crizotinib's activity in advanced ALK-positive lung cancer, but this is actually an update to Dr. Kwok's New England Journal publication on Crizotinib, the phase 1 trial of Crizotinib. This was recently published in Lancet Oncology, showing about almost 150 patients, 150 first ALK-positive patients that were treated with Crizotinib and their response, and again, a beautiful waterfall plot showing these marked responses to Crizotinib. Similar data has also been seen now in the global phase 2 study of Crizotinib, again, in advanced ALK-positive lung cancer. These waterfall plots almost look identical because basically almost all ALK-positive patients will have these types of responses to Crizotinib. And based on the response rate in those two studies, that led to the accelerated approval of Crizotinib in the US a little over a year ago. So this was based on response rate. It wasn't based on progression-free survival or overall survival, just purely on response rate. And the other notable thing about the label in the US is that Crizotinib was approved for advanced ALK-positive lung cancer regardless of prior therapy. So really no requirement that patients receive prior chemotherapy. And this, of course, has led to guidelines in the US as well as in other countries for diagnosing and managing patients. So in this country, NCCN recommends that we do upfront ALK testing by FISH, which is the FDA-approved diagnostic at present. And for those patients who are found to be ALK positive, the recommendation is to treat with Crizotinib. Now remember, this is all data that was based on the phase 1 and 2 studies, really not based on any randomized data. So of course, we've been waiting anxiously to hear about randomized data, and we finally had that and presented that at ESMO this year. So this is the first randomized phase 3 trial of Crizotinib in advanced ALK-positive lung cancer. And here, these are patients who are, again, ALK-positive using the standard FISH assay. These patients all had locally advanced, but primarily metastatic or stage 4 disease. The requirement was that all patients had to have received one prior platinum-based chemotherapy regimen because we did want to do a very pure second-line trial in advanced non-small cell lung cancer. We allowed patients with ECOG performance status of 0 to 2, and we did allow patients to enroll who had brain metastases as long as they were treated, or if they were untreated, they had to be asymptomatic. So the target enrollment was 318. We actually accrued over the target enrollment and ended up enrolling 347 patients. These patients were randomized 1-to-1 to receive either Crizotinib as their second-line therapy or a standard second-line chemotherapy such as pemetrexed or docetaxel. I should note that those patients who were randomized to the chemotherapy arm and had disease progression were allowed to cross over to receive Crizotinib since it would not be ethically acceptable to deprive these ALK-positive patients access to the targeted therapy. The primary endpoint of this study was progression-free survival with standard secondary endpoints including response rate and overall survival. So this was a global study involving over 100 sites around the world, as shown here. And here are the characteristics, baseline clinical characteristics of the patients who enrolled on this phase 3 study. The bottom line is that in both arms, the Crizotinib arm and the chemotherapy arm, they were very well balanced in terms of baseline characteristics and obviously the stratification factors that were used. Again, these are younger patients, a pretty equal balance between men and women. We had almost 50% Asian patients on this study, and these patients were by and large never smokers with adenocarcinoma. Down here you can see that we actually had about 35% of patients who went on study who had a history of brain metastases, and that's pretty common to see with ALK. It tends to be a disease that presents with, in the metastatic setting. So here's the primary endpoint of the study, progression-free survival, showing that the study did meet its primary endpoint by showing the superiority of Crizotinib over standard second-line chemotherapy. Here we had 227 PFS events with 100 in the Crizotinib group and 127 in the chemotherapy group, and you can see that clearly the PFS with Crizotinib was much better than with chemotherapy. Median was 7.7 months as opposed to just 3 months with chemotherapy, and this is obviously highly statistically significant. We looked across different subgroups of patients that were defined by baseline characteristics or stratification factors, and you can see that for basically every subgroup of patients that we looked at, there was a benefit to Crizotinib over chemotherapy. So this is a very robust difference in PFS. Well, what about response rate, which was a secondary endpoint? Again, no surprise given that large difference in PFS, that the response rate was about tripled in patients who received Crizotinib compared to patients who received chemotherapy, so 20% versus over 60%. And even though there was, I think, some enhanced sensitivity to one of the chemotherapies, pemetrexed, with a response rate of 29%, that's still inferior to the response rate with Crizotinib at over 60%. Well, what about overall survival? Well, this is a difficult analysis to do. There was an interim overall survival analysis that was pre-specified at the time of the final PFS analysis, but there are only 40% of the required events for the final OS analysis, so it's still a very immature study. In addition, as I mentioned up front, we did allow patients to cross over from chemotherapy to crizotinib, so that, of course, will confound the analysis of overall survival. And in fact, we did have about almost 90% of our patients cross over from chemotherapy to crizotinib. So shown here are the overall survival curves. You can see there's really no difference between the crizotinib and chemotherapy groups, and I believe it's for those two reasons, that the overall survival analysis is still immature and also confounded by crossover. And I think even on final OS analysis, that we probably won't see any difference between the two groups because of the significant crossover. Just for comparison, Jean-Charles did this in the discussion of our abstract here. He wanted to kind of give some context to the overall survivals that we were seeing. The overall survival in the patients that were on our study was over 20 months from second-line therapy, which is really a remarkably long overall survival given what we know about advanced non-small cell lung cancer, where median overall survival from diagnosis typically is only 12 months. So here we're seeing over 20 months from second-line therapy, and so that is quite long. And so Jean-Charles kind of wanted to juxtapose these overall survival curves that we're seeing for ALK-positive patients treated with crizotinib compared to kind of a general lung cancer population that really doesn't generally have any targeted therapy options. And here you can see overall survival is more like 8 or 9 months from second-line therapy. Very hard comparison to do because this is an ALK-positive group. These are a group of adenocarcinomas, probably a minority of which were ALK-positive. But the point is 20 months for overall survival is very, very prolonged, and there's almost certainly a survival benefit from crizotinib, but we may not be able to see it in a randomized trial due to crossover. What about side effects? Well, we talked a little bit last year and the previous year about how well tolerated crizotinib is. It really is, I would say, probably one of the easiest drugs that we use in our lung cancer patients. And so here was a summary that we presented of the side effects of crizotinib compared to the side effects of chemotherapy in the phase 3 trial. You can see that crizotinib, of course, does have some side effects. These were all known from previous single-arm studies, including the characteristic visual disturbance, GI side effects, elevated transaminases, edema, et cetera. And then there were, of course, some side effects that were more common with chemotherapy, not surprising, fatigue, alopecia, rash, that sort of thing. But by and large, these were mostly mild grade 1 or grade 2 side effects and pretty manageable. The one that stands out here is elevated transaminases or transaminitis from crizotinib. Again, this is a known toxicity of crizotinib, where we saw about 16% of patients with grade 3 or 4 transaminitis. So that is a significant percentage and one that we want practitioners to be aware of. So liver function does need to be monitored closely on crizotinib. Well, I think one of the most important analyses that came out of this was really looking at patient-reported outcomes. How do patients feel on crizotinib compared to chemotherapy? And I think this is very consistent with what we might expect if a drug is working well and has minimal side effects. So what we saw for both symptoms and quality of life is that patients reported a greater improvement from baseline if they received crizotinib compared to if they received chemotherapy. That was true for many different disease-related symptoms and also true for many different domains assessing quality of life and function. So shown here, for example, are the differences in the two groups in terms of changes from baseline, and you can see that in pretty much every case for global quality of life, for all of these different functioning domains, patients were doing better if they received crizotinib compared to chemotherapy. So to summarize the phase 3 trial, we now know that compared to single-agent chemotherapy, crizotinib prolongs progression-free survival, improves the response rate, and I think importantly, improves symptoms and quality of life for our patients. The side effects that we saw with the phase 3 trial were consistent with what we know about crizotinib's safety profile from the phase 1 and 2 data. And these results finally do really establish crizotinib as the standard of care. This is no longer based on single-arm data. This is now based on phase 3 data showing the superiority of the targeted therapy crizotinib to chemotherapy. So based on this actually has led now to approval of crizotinib in Europe. Europe had actually held out on approving crizotinib until they saw randomized phase 3 data, so now we finally have it, and this drug will almost certainly have global regulatory approval soon. So let's end now with, like I said earlier, what probably is the biggest hurdle in the targeted therapy field, which really is this problem of resistance. I'm going to show you an example of a patient of mine, and this is very emblematic for most of our patients, in that they generally respond extremely well initially to the targeted therapy, but at some point in the future, typically after about anywhere from 8 to 12 months, patients will have disease relapse. So this is one of our patients, one of the very first patients, ALK-positive patients, who went on to the phase 1 Crizotinib study. She had a lot of disease at baseline when she went on, as shown here. And she had one of these phenomenal responses to Crizotinib, a near complete response as shown here, and she did extremely well for about 2 years. And then her disease started to come back in these same locations. She was still feeling great, so she continued on Crizotinib as we typically do with targeted therapies. And she had slow progression of her disease over about the next 10 months or so that by about 3 years, she had to come off Crizotinib because you can see now that all of these tumors that she had originally had grown back. So this illustrates the problem of what we call acquired resistance, and it really is fairly uniformly seen with our targeted therapies. Now, we and others have actually been working very hard to look at the mechanisms of acquired resistance to Crizotinib. There's a lot of data out there looking at resistance mechanisms in EGFR mutant lung cancer and BRAF mutant melanoma. We've been focusing a lot on Crizotinib-resistant ALK-positive lung cancer, and this is just a summary slide to illustrate some of the main classes of resistance that we've identified in our patients who have become resistant to Crizotinib. You can see that about a third or a quarter of our patients have become resistant to Crizotinib because they now have a change in the ALK gene itself. Most commonly, it's a change involving an acquisition of a resistance mutation within the ALK tyrosine kinase domain. One of those is the gatekeeper mutation, L1196M, which is formally analogous to the EGFR T790M mutation. But there are actually many other ALK resistance mutations as well that can confer high-level resistance to Crizotinib. And you can also see amplification of the ALK gene itself, sometimes together with resistance mutations. But in the remaining cases, that's about another 2/3 of cases, we actually don't find any abnormality in the target, but we are sometimes able to identify evidence of bypass track activation, meaning activation of alternative growth pathways that can now bypass the inhibition of ALK. And these bypass tracks include EGFR as well as c-KIT and probably many others, but we do find EGFR activation as a pretty commonly utilized bypass track mechanism in Crizotinib resistance. You can see here by the gray portion of this pie chart that unfortunately we still don't know the resistance mechanism in a large number of our patients, so there's still much more work that needs to be done. This idea about identifying resistance mechanisms is important because, of course, the hope is that if you understood resistance, you would be able to then identify a strategy to overcome that resistance. And so when we were first studying Crizotinib resistance, we were imagining that here we have the different resistance mechanisms that we've identified, and here's our strategy based on those resistance mechanisms, and here are potential drugs that we can use, sometimes singly or sometimes in combination, to overcome the resistance mechanisms. But what I'm going to show you next is one of our drugs, actually two of the drugs, LDK and ARID, which are next-generation ALK inhibitors that we were originally envisioning might have activity in just that group of patients, the 1/3 of patients who have some alteration in the target gene. But what I'm going to show you is that actually these next-generation ALK inhibitors appear to be extremely effective regardless of the precise resistance mechanism. So this was a bit of a surprise to us. So let's talk about LDK-378. This is a next-generation ALK inhibitor that's made by Novartis, and it's very potent. It's probably about 5 to 10 times more potent than Crizotinib. Unlike Crizotinib, LDK does not have any significant anti-MET activity, and it does have some activity against IGF-1R, so those are two differences from Crizotinib. There are many preclinical studies done at Novartis as well as here looking at the activity of LDK in preclinical models of resistance. And we knew from the preclinical models that LDK could overcome many of the different resistance mutations that we had identified in patients. Shown here are some xenograft experiments showing that LDK has activity in vivo as well against some Crizotinib-resistant models. So this was the basis for going forward with a phase 1 study that was launched in the spring of 2011, so just about 18 months ago. This was a pretty typical phase 1 study design where there was a dose escalation phase to be followed by dose expansion at the MTD, or maximum tolerated dose. And of note here, we were actually, even for the dose escalation, we had limited the patients to be ALK-positive, that meaning that they had to have some genetic abnormality of ALK. We weren't enrolling all comers. And then, of course, for those dose expansion cohorts, this focused on patients with ALK-positive lung cancer who had received Crizotinib recently or had never received Crizotinib, or other non-lung ALK-positive cancers. And so here are the patients, the first 88 ALK-positive patients who enrolled on this phase 1 study of LDK. And this is data we presented at ESMO as well. And the main point here is to show that most of the patients so far who have enrolled on this phase 1 study were patients with ALK-positive lung cancer. And most of those patients with ALK-positive lung cancer had received prior Crizotinib. So these are patients who had developed resistance to Crizotinib. Now, this is our first patient that we put on this study. This was a global study, but this is the first one at our site. So our first experience with LDK already suggested that this was a very promising drug. This is a patient of mine, a younger patient who was 24, who had very advanced disease, had relapsed on Crizotinib, and you can see he had extensive FDG-avid disease throughout his chest. This patient actually happened to have a known resistance mutation, so we were hoping and predicting that this patient would respond to LDK, and sure enough, he did have a dramatic clinical turnaround, as well as this radiologic response as well, showing a really nice improvement in his FDG-avid disease. And here are CAT scans from the same patient confirming a partial response. You can see this extensive disease throughout both of his lungs that really had a really nice clearing after just under 6 weeks of LDK therapy. Well, this is not obviously the only patient who's had a response like this. As I said, now there have been over 80 patients who have enrolled, and what I've shown you here is a summary of the tumor responses in patients with ALK-positive lung cancer who had received doses of LDK from 400 to 750. 750 is now the established MTD of the drug. And you can see that almost all patients with ALK-positive lung cancer who are treated with this dose of the drug have response to LDK 378. And this includes patients who had received prior Crizotinib, shown by the blue bars, as well as patients who had never received Crizotinib. So this is a very highly active drug, even in the setting of TKI resistance. What I wanted to point out here is that we know the resistance mechanism in many of the patients who became resistant to Crizotinib, and I think what's really interesting is that many of these patients did not have resistance mutations. So this drug, LDK, is very active even in the absence of a resistance mutation. Here's the actual numbers that we've seen in terms of response rates. So in those patients who have received prior Crizotinib, they've relapsed on Crizotinib, and now they enroll on LDK, and they've received a dose of 400 milligrams and higher, the confirmed and unconfirmed responses are close to 80%. That means almost all patients will have a significant response to LDK. There's been some question about the activity of LDK and Crizotinib naive patients. The truth is we don't yet have the data on that group of patients, so we have to wait a little bit longer, but so far we are seeing responses as well in the Crizotinib naive group of patients. And then I think this is one of the most important points as well, that, again, these are not transient responses. These are pretty durable responses. So among the patients who actually achieved a partial response, as I mentioned, that was close to 80% of our patients, the median duration of response was over 7 months. So you're getting close to what we're seeing with the median PFS with Crizotinib. So very, very durable responses, particularly when you're thinking about a TKI-resistant group of patients. One last point about LDK, and then we'll move to the AP26113 drug, is that we've now started to see some activity of LDK in brain metastases. As I mentioned earlier, many patients with advanced ALK-positive lung cancer do have brain mets. As I said, it was about 35% of those patients who enrolled as second-line patients on the phase 3 trial. So it's a very, very common problem and the most common site of relapse for our patients on Crizotinib. Shown here is a patient of ours who had a new asymptomatic brain metastasis in the right occipital lobe. When we started screening him for LDK, he was not treated because he was asymptomatic. He enrolled on LDK, and after 7 weeks, had a near complete response in this brain lesion. So there is some activity of LDK in the CNS, which is very, very exciting. And finally, just to show you the adverse events with LDK, LDK is a bit tougher than crizotinib in terms of side effects. The main side effects are GI, nausea, vomiting, diarrhea that occur in a little over 50% of our patients. There are some other side effects as well that aren't too surprising here, but overall, it's a generally well-tolerated drug with sort of side effects that can generally be managed. So finally, just talk a little bit about the ARIAD compound, AP26113, also a very potent and selective ALK inhibitor, and I'm just going to show you a little bit of data on this. This is basically preclinical data showing that the AP26113 compound, like LDK378, is very potent, can overcome resistance in many different preclinical models of crizotinib resistance. And this led to a phase 1/2 study of this compound in ALK-positive, primarily ALK-positive patients. We're not going to talk too much about another potential activity of this compound in EGFR. But in any case, this is the phase 1 study. This was presented by Dr. Gettinger at ESMO, and I just wanted to show you the activity of this compound so far. So in ALK-positive patients, again, the activity of this 113 compound is very high, similar to what we're seeing with the LDK compound, that most patients who are ALK-positive, even if they've relapsed on crizotinib, will have a response to this more potent ALK inhibitor. So here it's 8 out of 11 of the ALK-positive patients and 6 of the 9 crizotinib refractory or resistant patients. So very, very good activity with yet another next-generation ALK inhibitor. So to summarize, before we take questions, we now know that crizotinib is a standard therapy for patients who have advanced ALK-positive lung cancer. This is based not only on phase 1 and 2 data, but now finally on phase 3 data as well. There is an ongoing frontline study of crizotinib versus first-line chemotherapy. However, I think the data so far is very supportive of using crizotinib as the standard therapy even in the frontline setting. Based on the data we've seen so far with ROS, as well as understanding the biology of ROS, I think crizotinib should and hopefully will become a standard therapy soon for patients with advanced ROS-positive lung cancer. And what we've seen now with LDK and AP26113 is that more potent ALK inhibitors can actually salvage or rescue most of our patients who relapse on crizotinib, and this is regardless of whether or not they have a resistance mutation or not. So what are we planning right now? Well, there's lots more work to do in terms of understanding the next generation ALK TKIs, in particular understanding how to use them. Do we use them purely in the refractory setting? Do we use them up front? There are going to be studies, phase 2 and phase 3 studies now looking at next generation ALK inhibitors compared to crizotinib. I think we need to better understand how these next-generation ALK inhibitors really are working. Are they truly overcoming resistance, or are they just providing more potent inhibition of the target itself? It's really not clear right now. And unfortunately, we are already beginning to see resistance develop even to these more potent next-generation ALK inhibitors. And so a large effort of ours now is to understand these resistance mechanisms. And if we can understand these resistance mechanisms, perhaps we can develop new treatment strategies. Finally, I think it's inevitable that we have to be thinking about combinations for these TKI-resistant patients. I think monotherapies can certainly work very well. We've seen durations of benefit, 8 months, 12 months, 24 months, but certainly these are not long-term, many years of benefit, so we definitely need better strategies, and these almost certainly will involve combinations of targeted agents and almost certainly will require some kind of creative dosing schedules in order to be able to effectively inhibit the targets of interest. And I'll just end here with my acknowledgments. Many people at Mass General, in particular Dr. Engelman's group, who's done all the resistance work with us, the pathologist, Dr. Ayafredi, Dr. Mina Knudsen, who've really been essential, actually, to all the work that we presented. The whole network of crizotinib investigators, as well as LDK and 113 investigators. And I think I'll end there and take questions. Thank you.
Alice, we have a few minutes for questions. Can you give us any clues as to how tumors become resistant to the second-generation drugs? Have there been any attempt to select resistance in culture, and
Yep.
what do you find?
So we've done both. So we unfortunately have the patients who are becoming resistant to the next generation ALK inhibitors, and we rebiopsy or attempt to rebiopsy all of those patients to study the tumors that have become resistant kind of in vivo. And then we, of course, have many different cell line models that we've cultured with next generation inhibitors in order to make them resistant as well. And we have some emerging data, and I think it's a similar concept in terms of the idea of potentially having very highly resistant mutations within the target itself. So these are potentially pan-resistant mutations across all ALK inhibitors. And also, again, we're seeing some resistant tumors that really have no identifiable changes within the target itself, but clearly have bypass tracks. And it's going to be more complicated than just EGFR and c-KIT.
Okay, Alice, one question. When you see patients with gatekeeper mutations that are resistant but still respond to the second-line agents, is the gatekeeper mutation a minor allele within the population, or is it really the predominance of tumor cells that have this mutation?
You know, it's a bit of a hard question to answer. Right now, we're still using kind of a crude method, just Sanger sequencing of the resistant tumor samples, and I would say it varies, meaning sometimes it seems like it's a smaller proportion, and sometimes it seems like we see a lot of the mutant allele. And part of the complexity, of course, is that, as you know, these biopsies often are contaminated by non-tumor cells. Quite a few non-tumor cells, stromal cells, you know, lots of times these tumors have a really prominent desmoplastic response. And so it's a little bit hard looking so far at the tracings that we have to really get an estimate of the tumor, you know, how much of the tumor itself has the mutant allele.
Do the ALK-positive tumors, are they less responsive to chemotherapy, pemetrexed, and docetaxel?
So it's a good question. As we showed in the phase 3 trial, the response rate was really remarkably high with single-agent pemetrexed. A response rate of 29% is very high. We would normally expect a response rate of 10% or less for second-line patients. However, the PFS on pemetrexed was only about 4 months, which is pretty similar to what we might see for the general population of adenocarcinomas. So ALK positivity seems to make tumors more responsive to pemetrexed, but it's not a very durable response.
But that's important in terms of
It's
thinking
important.
about combinations, right?
Yeah, it is important. So certainly pemetrexed would be my first choice for chemotherapy in an ALK-positive patient.
So Joe and I think alike. Is there any plan to look at using pemetrexed with an ALK inhibitor, either intermittently or concurrently?
There is a trial that just got started looking at that combination, and then there's been discussion about trials that will allow us to, when patients progress, add chemotherapy to the crizotinib. We do that very routinely with EGFR TKIs, where they have progression, and now we add chemotherapy to the EGFR TKI, and we would like to be able to do that for ALK as well. So those trials are underway.
Okay, one more question, Susan.
In thinking about combination therapies, have you thought about combining TKIs with immunotherapy? There have been some recent advances in that area.
We have. So that probably is a very important area to look at. I think we're still, of course, establishing the role of the TKIs as monotherapy. And of course, as I mentioned, going to combinations, including with immunotherapies, is very important. There are some studies, for example, with EGFR TKIs and immunotherapy, and I think we'll be moving that way for ALK TKIs as well.
Okay, one last question.
Bruce, could I make an editorial comment? We ought not be too jaded to remember that from the time Mano's paper in Nature was published until the registration of the drug by the FDA, including its companion diagnostic, was less than 4 years. Mm-hmm. That in itself is remarkable, but made so by the tremendous collaboration and leadership of MGH and you in particular, Alice. And what you've just now shown us, the follow-on of that, is, if anything, at an even greater pace. So whatever you're doing it supremely right, and we all ought to learn from you.
Thank you. So it was a tremendous collaboration among, I think, many investigators around the world. That's why it worked so well, because there are so many investigators who are really dedicated to developing this drug for the patients. Thank you.
Okay, well, thank you so much.